presenter is he is a Regional Overdose Prevention Specialist, also known as a ROPES, with the Memphis Area Prevention Coalition. Josh has been involved in the Shelby County recovery community since 2001 and is in recovery for alcohol and opiate addiction. He received his Bachelor of Science in Nursing from the University of Memphis in 2011 and is a registered nurse with the state of Tennessee. Josh is not only a coworker of mine, who I have been fortunate enough to work next to, but he is a good friend, and I'm excited to hear what he has to say. His presentation is The Biology of the Addicted Brain. So please help me welcome Mr. Josh Weil.
Thank you, Austin. Can you hear me?
Yes, yes.
All right, good deal. All right, well, like you said, my name is Josh Weil. I have a Bachelor of Science in Nursing. I'm the Regional Overdose Prevention Specialist for Shelby County. And today I'm going to go a little bit off the beaten path for me. I usually do Narcan trainings. This is part of the training, but it is not quite as comprehensive. And this topic, to me, we've heard a lot about stigma today. And I think a lot of the stigma is because of a lack of knowledge of what is really going on when we see someone with alcoholism or substance use disorder, you know, and this is, like Chris said, this is a piece of a very complex puzzle, but it's a very important piece, because what tends to happen is people tend to look at the behavior associated with substance use disorder and not understand what's going on behind that behavior. And, you know, if you want to see stigma in action, go to any social media platform and write "addiction is a disease" and wait about 5 minutes and see what happens. Because there is a controversy, you know, they call it the disease concept. Is addiction a disease or a choice? And this is not a concept. Addiction is absolutely 100% a disease. It is characterized by chemical changes, changes in the brain, and predisposing conditions, just like any other disease. So this is what we're going to go over today. We're going to look at addiction, you know, why it's a disease. I see a lot of presentations, and this topic is rarely covered or rarely covered in depth. And, you know, and I've got this disease. I used opiates for about 15 years, alcohol since I was a teenager. And I classify myself as an alcoholic and someone with substance use disorder. So it was always very confusing to me why I was doing what I was doing, you know, why, despite my own decisions, motivations, ideas, I would continue this behavior. And, you know, I often hear that in presentations, well, addiction is a disease. Well, why? What makes it a disease? You know, help me to understand what is going on in my brain. And it was revelatory for me to hear this information and to find out, you know, what was really going on with me. So we're looking at why some people get addicted and some not. And this is, you know, for me, people that I drank with or used drugs with when I was younger, most of them went out about, you know, getting a life. They'd get married, they were buying a new boat, getting a new job, and I couldn't seem to cross that barrier. These behaviors kept reappearing in my life, and it was preventing me from having any kind of success. So, you know, and the universal ideas about addiction and substance use disorder, alcoholism, is that this is some kind of moral issue. Do I have a weak will? Am I a bad person? I didn't think I was a bad person, but these behaviors, you know, looking from the outside in, all we see is the decisions being made, and a lot of them are very tragic and they don't make any sense. And so, you know, what is the difference between someone with substance use disorder and somebody that can use substances and just move on and, you know, leave it behind them? So what happens to the brain with chronic substance use? And we're going to look at some of the changes that take place in the brain, particularly in the limbic system. This is not by any means fully comprehensive. This is a simplified look at what's going on in the brain. There are a lot more areas of the brain and neurotransmitters involved. This whole process is not fully understood by science at this point, but there are particular areas of the brain that have been studied that are all involved in addiction, and we know they're involved, and we can actually measure the changes going on and see kind of what's happening there. And then we're going to take a look at alcohol. And, you know, because of the way alcohol is socially accepted, we're going to compare it to other drugs and see if alcohol is in the same category as other drugs. In this case, we're going to be looking at alcohol against opioids. And then we're going to look at some treatment options as well. So back in 1959, Doctors McLaren and Rogers did a study. And what they did is they inbred mice for about 20 generations. And what that does is it creates groups or genetic strains of mice that are identical to each other. So the male mice, after inbreeding like this, are about 98% identical genetically. And what they did was put them into groups, and each group had an identical genetic strain. So in essence, they were clones of each other. And they made psychoactive substances available for self-administration to these groups. And what they found was some of the groups, the whole group would go for drugs and alcohol over and over and over again. Other groups would leave it completely alone. Now, they noticed, so some groups had habitual behavior concerning substances. Some groups were completely abstinent. Other groups were intermediate. They could kind of take it or leave it. I guess they were the social drinkers of the mice group. But what they figured out from this is that there was something genetic going on as far as substance use disorder. So they knew that some groups that shared this genetic strain were more apt to go back again and again. And didn't quite know why yet, but since then, we've done a ton of studies. And what they have found so far is that there's about 90 genes associated with addiction. So there is not a single gene that will say you're an alcoholic, you're likely to be addicted to opioids. It is a combination of these genes, and we see these genes in most addictions. Now, this is by no means the only way someone can become addicted to something. Repeated use of a substance can damage the brain system, and it can begin to have this reaction the same way somebody that is genetically inclined to use a substance does. And what these genes determine are things like affinity to the receptors for that particular substance. So receptor affinity denotes how long and how tightly that substance will attach to that receptor. Receptor sensitivity, so the effect that a substance has on the receptor. So will it activate that receptor in a big way, or will it barely activate it at all? Someone with very low sensitivity in their receptor will need more of a substance in order to get the same effect as someone with high sensitivity in that receptor. Some people with low sensitivity in their receptors, that substance will not even work for them. They determine metabolic process. So that's how quickly the body will break down that substance. They can also determine enzyme levels. So enzymes that break down that substance can be in a greater amount in somebody, genetically, because of the way their genetics are. They can have more enzymes to break down a particular substance. So what does all that mean? And what does that look like in layman's terms? Well, what that means is that people experience substances differently. So opioids are a great example. If you've ever been to a doctor and gotten a pain pill, like a hydrocodone or Percocet, an opioid pill, most people, and this was shocking when I found this out, being, an opioid user, most people do not experience pleasure when they take that pill. So what we usually see, about 9 out of 10 people, most studies show about 10 to 20% have genetic susceptibility for any given substance. So about 8 or 9 out of 10 people will take that pill. They will get sick to their stomach. They will get itchy. It is not a pleasant feeling. They will take it till the pain is gone and then stop. Now, people that are genetically susceptible to opioids can take that same pill, and it can be the experience of a lifetime. So in my experience, I felt warm all over, just this big rush of euphoria, extra energy. So it is a completely different experience. It's the same thing with alcohol. So when someone who is susceptible to alcohol or an alcoholic says, I'm drunk, and a normal drinker says, I'm drunk, they are talking about two completely different things. But being unaware of that, I used to hear people say, well, I've taken that, or I drank and I just put it down. I just leave it alone. I don't understand what the big deal is. Why can't you stop doing this? Well, what I was experiencing and what that person was experiencing were two completely different things. And it ends up looking like an elevated pleasure response is what it is for someone that is more likely to become addicted to something. Now, if I'm genetically susceptible to a substance, does that make me addicted to it? And the answer, of course, is no. But what it does do, it makes me more likely to continue to use that substance. And that's where we really get into trouble with the brain. Now, Chris was talking about trauma and adverse childhood experiences. I think someone with a high ACEs score is something like 30 times more likely to end up using intravenous drugs. Well, I want you to think about this. So if someone's genetically susceptible to a substance and they have had trauma, they have a nervous disposition, they're painfully shy, they're not comfortable in their own skin, they take that substance and it's a revelatory experience for that person. Why haven't I felt like this before? Someone that may be comfortable in their own skin for the first time in their life, this is how I'm supposed to feel. That person is much, much more likely to continue to use that substance, right? Because it has more of a payoff. So, all this, the social, the environmental, it's all intertwined. And we're going to look at what is referred to as the hijacked brain. So this is what happens with chronic use when use is continued. And this ends up happening to a lot of people that are prescribed pills by a doctor who, have to continue taking this substance. They're genetically susceptible. They have this increased reaction. So this increased response triggers the rest of the system to have an increased response also. And this is in what's called the pleasure reward circuit. And this is designed to help us survive. It's located in the limbic system. We're going to look at 3 areas of the limbic system. We're going to look at the nucleus accumbens. That is in your basal ganglia. We have 2 of those, one on in each hemisphere. And that is what is known as the pleasure center of the brain. It doesn't necessarily cause the pleasure. That is a much more complex issue. But we have a learning system in our brain, and the nucleus accumbens is kind of the arbitrator of that. And it determines what behaviors we are going to continue. We're going to look at the ventral tegmental area, or the VTA. It's right on top of the brainstem. And it is a very, very primitive part of the brain, and it is involved heavily in this process. And we're going to look at the role of dopamine in addiction, which has been very misunderstood for a very long time. It's something that's seen in every addiction, including non-substance addictions, sex addiction, gambling addiction, things like that. And then we're going to look at the role of the prefrontal cortex in addiction, which is the thinking, rational part of the brain. So we all have a drive to survive, right? This is where, if we were in person, I would ask everyone who likes food and sex to raise their hand. So here, I'm just going to assume that everyone is raising their hand. Now, there's a reason why we all like these things. We are wired to continue behaviors that help us to survive. So we have this system in our brain that takes things that are good for our survival and tries to ensure that we continue that behavior. Now, a great example, and so everyone can relate. I always use this example. If you've ever gone on a diet and said, well, I'm going to exercise, I'm just going to eat chicken and brown rice today, and you made that decision and you're firmly going to stick to it, and then by 2 o'clock you have a chocolate donut in your mouth, then you kind of understand at some level what's going on here. So sugar creates a strong response. It's good for our survival. It's instant energy, stored energy. Our brain loves it. So our brain wants us to continue that behavior. But if you look at it in that context, you did something against your own will, right? We made a decision and yet we did something else. Well, why did we do that? And that's kind of what we're going to look at. And it's the same mechanism that is happening when we're dealing with a person that has substance use disorder. So this is kind of, you see where the limbic system is in the brain. This is where it all happens. And then the prefrontal cortex is involved in this as well. So we're going to look at the nucleus accumbens first. Nucleus accumbens is known as the pleasure center of the brain. Now, things like food and sex activate the nucleus accumbens. Like I said, things good for our survival will activate this area of our brain. They activate it indirectly. Substances like alcohol, opioids, meth, cocaine act directly on the nucleus accumbens. We get a much higher than normal level of activity when substances get involved. So a substance is taken and it fires off the same mechanism as things that are good for our survival. This is not a thinking part of the brain. It does not know the difference. You're essentially tricking the brain into thinking something harmful is good for you. And in turn, we have this massive response from the nucleus accumbens, right? And this notifies the ventral tegmental area, or the VTA, that area that's on top of the brainstem. So the ventral tegmental area will respond to nucleus accumbens or pleasure center activation. And in response to that, it will release dopamine. It releases dopamine into the nucleus accumbens, but it releases it at a much higher level than anything that you would normally come across would. So it was generally thought for a long time that dopamine was related to pleasure, that dopamine was causing the pleasure. Because like I said, it was seen in every addiction in mass quantities. So they're like, oh, well, it's releasing dopamine and that's causing pleasure. But that is not the case. Some of that did not make sense because people with Parkinson's, they have low dopamine, right? But they still experience pleasure. And they also found out that your VTA releases dopamine in unpleasant situations as well. So that kind of made them go, something's going on here that's not right. So there were a few studies done. Wolfram Schultz studied with some macaque monkeys back in the 80s and 90s, and he was experimenting to monitor dopamine levels when something pleasant was given to the monkey. And so what he did, he set up a light on the wall. The light would go off. The monkey had a straw in its mouth and he would give it some really sweet juice after the light went off. So at first, this dopamine rush would be released when the monkey got the juice. It would happen simultaneously at the same time. Eventually, what he noticed is that, so an unexpected reward produced a rush of dopamine. What he noticed eventually is that the dopamine would release when the light came on. So when the light came on, this big rush of dopamine would come out. When the monkey drank the actual juice, there was no dopamine released, but he did not experience the pleasure of it any differently. So the level of pleasure remained the same, but the dopamine was released before. Now, if you think about that in terms of alcohol and drugs, we have things called triggers, right? So an alcoholic is passing a liquor store and gets a sudden craving for alcohol. Or someone who uses opiates sees a needle, they get a sudden craving to use. And this is kind of what was determined from that. Another study was done by Barrage and Robinson, where they used genetically altered mice and rats. And these mice and rats were altered in a way that some produced no dopamine and some produced excess dopamine. And what they noticed is the motivational behavior in the animals changed. So the mice that had extra dopamine were much quicker to move to food and sex and things that are related to their survival. Didn't seem to enjoy it anymore. And then the mice that had no dopamine at all would sit and starve to death with food right next to them. But when they were hand fed, they seemed to experience the same amount of pleasure. So they called it, Barrage and Robinson called it incentive salience. And so what they determined that the dopamine does is it motivates behavior. So it creates a want or a craving. So when, for the sugar example, when you ate the chocolate after you said you were going on a diet, this is what was going on. We were having dopamine release and it was motivating us for that behavior. Now, this is not the kind of motivation or want where you plan it out, like, okay, I'm going to go to school, I'm going to do this, and this is what I want to do. This is a craving. This is something that you either can overcome or not. Now, if you couldn't overcome that craving for sugar, I want you to imagine a craving 5 to 10 times more intense than that. And that's kind of the level of dopamine that is released when we're talking about substances. If you look at this chart, you can see where food and sex is right at the beginning of the chart. And as we look through these substances, this is the intensity of the amount of dopamine released from substances. Alcohol lies in there between cocaine and methamphetamine, but that's what a person with substance use disorder or alcoholism is dealing with. So this is a mechanism that is pushing them to do something. As a matter of fact, it is, your brain is telling you, this is the most important thing you have to do. This is the most important thing you've ever done, because as far as those areas of your brain are concerned, you have hit the jackpot. It doesn't differentiate that these chemicals are coming from something that's harmful. It just knows it's getting more of these chemicals it associates with survival. So it is going to push in order to continue that behavior. So we do have a system in place to overcome these cravings. So if you've ever decided you're going to go on that diet and you're successful, it's because we have a big prefrontal cortex, right? We are human beings. We have logical brains. We can reason with ourselves. This is our inhibitory system we use to override these cravings. So I'm able to use my logical thinking. Like if you think of it in terms where you look at your dog or look at animals and they just do whatever they want to do whenever they want to do it, right? They're following their instincts. They don't have that big prefrontal cortex where they can say, I'm not going to chase that ball across the street because there might be consequences. They'll just run out there and do it, right? Well, we have the ability to not do that. And this gives us the ability to choose not to succumb to these cravings. But here's the problem. With chronic use, the prefrontal cortex goes through some changes as well. The structures of the neurons actually change in the prefrontal cortex. They become misshapen. there is a reduction in mass. We will actually see the prefrontal cortex get smaller, and we have reduced activity. If you look at that picture, that shows a healthy brain versus a brain of someone with substance use disorder, and you can see activity is down. So what's going on is the system that we have in place to overcome these urges is diminishing. And what happens with the dopamine system and the nucleus accumbens in the VTA, it's increasing in sensitivity over time. So the urges we have are getting greater, and our ability to overcome those urges are getting smaller. So that is what a hijacked brain looks like. That person who is suffering in this manner can decide that they're going to stop. They can, make all these choices, and they can be intellectually motivated to know that they're tired of these consequences. They don't want to do it. And it is to absolutely no avail. That person's decision do not matter. This system is still going to be generating all this extra dopamine. It's going to be giving all these, these huge cravings, and the system that is in place to deny those cravings is being damaged at the same time. So it's very unlikely that any kind of consequence or a person's desire to quit is going to be of any avail. And, this is part of the reason why our relapse rate is so high. This is why it's so important that we get a person into treatment where they are physically unable to get that substance. I had to be put into treatment to where I could not, even if I wanted to, go get the substance that I was looking for. And it takes about 90 days for the brain to reset just to the point where it starts moving in the other direction. It can take up to 2 years before the brain gets back to the level that it was at before that person started using the substances. So this is what we're looking at in chronic use. So we have a predisposition for use to where it feels, person feels more pleasure. They get an elevated response. Due to that elevated response, it triggers the rest of the system to have an elevated response. And we end up with cravings that far outweigh our rational ability to deny those cravings. So we're going to compare alcohol, the most socially acceptable drug, to one of the least socially acceptable drugs. We're going to compare alcohol to opioids, just to kind of see if this applies to everything. So how is alcohol different than other drugs? Well, for one thing, it is legal, right? It is socially accepted. It is easily obtainable, and moderate amounts of it can actually be good for you. Alcohol dilates the blood vessels. It's good to prevent dementia. It actually lowers cholesterol. And, this is in very moderate amounts. Now, how alcohol is similar to other drugs, very, very strong evidence of genetic susceptibility. That study with the inbred mice, ethanol was one of the substances used, and there was a very strong reaction there. It binds to the body's natural receptors to create an increased or diminished response, just like every other drug. The body produces compensatory response that leads to tolerance and physical dependence. And then withdrawal occurs when the substance is no longer in the system. So these things are true for both alcohol and for opioids. So the way opioids work, their mechanism of action, they attach to opioid receptors, just like the body's natural endorphins. So endorphin means endogenous morphine. That's morphine that your body makes. And it is to decrease the pain response. It blocks the action potential of the nerve so it doesn't fire off and send a signal. And it reduces neuronal cell excitability, which creates a sedative effect in that person. It does activate the nucleus accumbens, and it can create that elevated pleasure response that can lead to chronic use. alcohol mechanism of action. So alcohol attaches to the body's natural NMDA and GABA receptors. So NMDA receptors are what glutamate attaches to, that excites neural activity. GABA reduces neural activity. So these cells, the receptors become less responsive to glutamate and more responsive to GABA, which decreases neural activity and creates a sedative effect. Sound familiar? It does activate the nucleus accumbens, and it can create an elevated pleasure response, which can lead to chronic use. So both of these drugs have a compensatory response, which leads to tolerance of a drug. So in response to alcohol, the body does something called regulation, and it will upregulate NMDA receptors. So because of this diminished response, it creates more NMDA receptors, and it will downregulate GABA receptors so that neural activity will be increased. And what that ends up looking like is that now it takes me more alcohol to get the same effect. If I want to diminish that neural response and get that sedative effect, I'm going to have to drink more now because I have more of these receptors in play. They're trying to achieve homeostasis. They want everything to be in balance. Your body does not like to be out of balance. And in response to opioids, the body downregulates the opioid receptors. So there are not as many receptors for the opioids to attach to. Now, when opioids go in the system, they do not target the receptors. They randomly come across them, they'll attach and activate those receptors. So the body wants there to be less surface area for those opioids to attach to, so it will create less receptors. And in return, you need more of the opioid to cover the number of receptors needed in order for you to feel the same way. So over time, you have to increase the amount that you take. Now, with chronic alcohol use, the number of enzymes that break down alcohol will increase in the digestive tract. So the body is going at more than one angle to try to straighten everything out. So it will break down quicker in the digestive system. And then again, you need more alcohol to achieve the same effect. Now, with opioid use, the production of cyclic AMP will increase. And what cyclic AMP does is it opposes the effect of the opioids. So where opioids slow everything down, cyclic AMP will speed everything up. Speeds up the digestive system, it dilates the pupils, increases muscle activity, increases blood pressure. So physical dependence and withdrawal. When alcohol is no longer present to inhibit the receptors, neural activity is dramatically increased. So as you can imagine, we've got all these extra NMDA receptors and not as many GABA receptors. And now there's no alcohol to balance things out. So what we're seeing in alcohol withdrawal and in opioid withdrawal really is the body functioning normal, but at an increased rate. So we've got this neural activity that is just off the chain. Symptoms of alcohol withdrawal include tremors, anxiety, nausea, vomiting, headache, increased heart rate, irritability, confusion, insomnia, high blood pressure, and nightmares. Severe withdrawal can cause DTs or delirium tremens, which is characterized by seizures, extreme agitation, hallucinogens, and can be fatal. And according to the World Health Organization, 140 million people are physically dependent on alcohol. That's more than any other drug on the planet. So, and just to note, you know, GABA is associated with memory, and they think, they're not, you know, specifically sure, but they think that's why people go into blackouts and have trouble remembering when they drink too much. And that is also why other drugs like benzos and barbiturates help with withdrawals, because they also affect the GABA receptors, so they can help to balance the body out. So when opioids are no longer present in the system, we have this extra cyclic AMP in the system, like I talked about, that is suppressed by the excess opioids or balanced out by the excess opioids. When the opioids are gone, the cyclic AMP level is off the chain, and it is speeding everything up. And we see that. Oh, and also the lack of opioid receptors. It's hard to function. Your body's pain relieving system cannot function at a normal level. So it increases sensitivity to pain as well. But what it ends up looking like is diarrhea, vomiting, nausea, restlessness, sweating, anxiety, muscle pain, abdominal cramping, increased heart rate and blood pressure, dilated pupils, insomnia, goosebumps, and tremors. And until that level of all these extra chemicals go down, you know, this is what it's going to look like. And that's, you know, people call it dope sick, but what it is withdrawals. And this is the physically dependent part. Alcohol withdrawals can be fatal. Opioid withdrawals are not. So consequences of chronic use of alcohol, we see heart disease, stroke, accidents resulting in injury, legal problems and incarceration, mental illness, liver disease or cirrhosis of the liver, and death. With opioids, abdominal distension from constipation, increased risk of HIV and hepatitis C if using intravenously, accidents resulting in injury, legal problems, incarceration, mental illness, endocarditis, and death, overdose. So as you can see, you know, very, very similar. Alcohol definitely qualifies, I think, as any other drug would. And in some cases, it's even more, you know, frightening. Recognizing alcoholism in yourself or someone else, you experience temporary blackouts or short-term memory loss, exhibit signs of irritability, extreme mood swings, make excuses for drinking, such as to relax, deal with stress, or feel normal, choose drinking over other responsibilities and obligations, become isolated and distant from friends and family members, drinking alone or in secrecy, feeling hungover when not drinking, changing appearance and group of acquaintances you hang out with, substance use disorder, develop cravings for drugs, are unable to stop or limit use, take greater amounts of drugs to feel the same effect, have withdrawal symptoms when you stop using the drugs, spend a lot of time getting drugs and recovering from their effects, give up activities so you can use drugs or recover from use drugs even after they cause health or physiological problems, and want to stop but can't. And, you know, as you can see, that goes back to what's going on in the brain when that system takes over and you're unable to make the decision to stop. So what does treatment look like? Now, also, I wanted to point out, they are actually, you know, Chris had mentioned pathways in the brain, and they're actually working on a drug that creates new pathways in the prefrontal cortex to help get that system back online to overcome those cravings. I don't think it's near completion yet, but it's something that's being considered and studied as a remedy for that survival system gone awry. So addiction is a complex but treatable disease that affects brain function and behavior, and no single treatment is right for everyone. People need to have quick access to treatment. So, you know, I think Tony mentioned that in harm reduction. There's a, you know, it's a very short window in which a person is actually ready to get help. So when they are, it is best to act very quickly to get them in while they're in that window. Effective treatment addresses all of the patient's need, not just his or her drug use. You know, if someone's in a bad environment and we say, well, here's a prescription for Suboxone, which is a medically assisted treatment drug for opioid addiction, and just send them right back to that environment, it's probably not going to do a whole lot of good. You know, we need to look at that person's living situation, psychological issues, anything else that's going on. Staying in treatment long enough is critical. And we talked about that, you know, time for the brain to heal and reset enough to where that person actually has some say in their own actions. Counseling and other behavioral therapies are the most commonly used forms of treatment. And of course, there are 12-step groups. Medications are often an important part of treatment, especially when combined with behavioral therapies. Treatment plans must be reviewed often and modified to fit the patient's needs. Treatment should address other possible mental disorders. A lot of people self-medicate because they have something else going on. Medically assisted detox is just the first stage of treatment that goes along with counseling and other things to follow. Treatment doesn't need to be voluntary to be effective. And you hear that a lot. Well, they've got to be ready. They've got to decide to do it. I know a lot of people that were forced by the courts into a 12-step program and they're still sober today because they heard something they needed to hear or they got motivated in some other way. Drug use during treatment must be monitored continuously, so tests and things like that. Treatment programs should test patients for HIV, hepatitis B and C, tuberculosis, and other infectious diseases as well, and teach people about steps they can take to prevent illness. Now, I said I usually do a Narcan training, and we will be doing a Narcan training for you all. If you scan that QR code, it will take you to Eventbrite. If you cannot scan that QR code, you can go to Eventbrite and put Community Narcan Training, Shelby County, and you should find this. We are having 2 that you can sign up for if you want to come. They're both going to be on Tuesday, the 13th. One's at 2 in the afternoon, and one is at 7 in the evening in case you're working Tuesday afternoon. So this is going to be an online training, and I will discuss how you can get Narcan, and also it will be available if you qualify for a kit at no cost. You will be able to get that as well from me if you're in Shelby County. I understand we have some people that are on a different continent on this summit today, and they probably won't be able to get one. But if you can get to Shelby County, we can see if you do qualify. So I will leave that up there for a second. And if we have any questions, I will take them.
Thank you so much, Josh. What an awesome presentation. That was awesome. And there are lots of comments of other people saying how much they appreciate it. It's always really fascinating to hear about the addicted brain and to hear the science behind it. All right, so let's go through some questions. All right, so Melissa wants to know, why is it that some with genetic susceptibility do not become addicted to drugs, but other issues like food or exercise?
Well, the issue about becoming addicted is not because you are genetically susceptible. It is when you continue to use. So I know a couple people that have actually used and they said it felt too good for them. So they stayed away. They decided at that point to stay away from it. And if you are able to stop using before the brain gets hijacked, then there's no reason why you would become addicted to it. Now, as far as the non-substance addictions, I don't know as much about them, but I do know it is the same exact system that is at work. So those cravings are coming from the excess release of dopamine. I know they actually even did a study of pedophiles and saw that dopamine release when it came to, their reaction to someone that was too young or whatever the case was. So this is going on in a lot of different things. I mean, this is kind of the human battle, right? It's always between our cravings and our instincts and our rational thought. And this is that system kind of being thrown out of whack. But if use is not continued, then the survival system never, goes into that mode. And we don't have that problem.
Awesome, thank you. Destiny wants to know, could the prefrontal cortex grow if the person quits substance abuse, or is the cortex going to remain the same forever?
No, the brain will, it will come back to its, if there's damage before you started chronically using, obviously that's still going to be there. But from what I understand, after the brain has healed completely, that will fix itself.
Okay. Do you think it will be possible or helpful to incorporate brain scans into treatment in the future?
It may be helpful, but I think it's not going to tell them a whole lot because we already know what's going on. You know, if they do develop a treatment for that, like they're looking into, and maybe we could see how far along, you know, that person's damage is to the prefrontal cortex, then maybe they could measure, you know, how they would treat it. But other than that, I think it's just kind of understood.
Okay. Felicia would like to know, is it possible to rewire our brains to expect and accept small amounts of alcohol after addiction has been experienced?
Very unlikely. If once you experience that reaction, I believe that reaction will stay the same. Your brain actually learns as it goes along, and if it has learned that substance, you know, creates that pleasure and, you know, is fooled into thinking it's good for your survival, when it is done again, I believe that the dopamine will be released at a bigger level. But I don't know if that has been studied in depth.
All right. We've got an anonymous attendee asking, what are the treatment options when it comes to cognitive damage caused by substance use?
That I am not sure. That would have to be done by a medical doctor, neurologist, probably.
Okay.
If there's actual damage to the brain, then that's a little bit above my pay grade. You know what I'm saying?
Right. And what are the side effects of Narcan?
So Narcan has no known side effects. What can happen with Narcan? So Narcan actually targets the opioid receptors just like opioids do. And they have a higher affinity for the receptor. So when the opioid gets on that receptor, it activates it, it comes off. The next opioid activates it, it comes off. The Narcan will come in, get on the receptor, will not activate it, and will stay on. So as a result of that, all the opioids end up floating around in the system with no place to land. So if that person is a regular user of opioids and will have withdrawal without them, they will go into what's called precipitated withdrawal. So a person can go into severe withdrawals when you give them Narcan if they are a regular opioid user and are physically dependent on it. And that actually is the only time Narcan can be fatal is to a newborn baby between 0 and 30 days old that was born addicted. The withdrawal symptoms can be fatal.
All right. And would you approach with non-substance addictions, would your approach with non-substance addictions be the same with treatment, considering it is more so an experience and not a tangible item?
There actually is over 300 different kind of 12-step groups established in the world, and many of them deal with non-substance addictions. So yes, the treatment for those types of addictions is extremely similar. Everyone I'm sure has heard of Sex and Love Anonymous, Overeaters Anonymous. So yes, the approach is the same in a lot of cases. I'm sure there can be, you know, other medically assisted things added with overeating. There's drugs that probably curb the appetite, things like that. But as far as, you know, like a 12-step approach, it's all the same. The steps are all the same for all of those addictions.
And do you find that some addictions are more generational versus having to do something with the brain?
Well, I mean, generational addictions tend to be, you know, genetically based. So, you know, we hear a lot, alcohol runs in my family. That's most likely that genetic susceptibility being passed down from generation to generation. And like Chris said, you know, your genes can actually change, and then those can be passed down to the next generation. So, you know, I think whether an addiction is environmentally based, whether that person was not born with genetic susceptibility, it all leads to the same issue with continued use. It's all the survival system getting hijacked and pushing these huge cravings out there and diminishing your ability to overcome those.
Right. We've also got the question, if a pregnant woman has Narcan administered, is it dangerous for her fetus?
As far as I know, it is not. But that person should be observed medically immediately. That is the instructions as far as someone pregnant that gets Narcan. They need to go, and be in the presence of a doctor as quickly as possible.
Okay. And is it possible to give too much Narcan?
I think there's a little bit of debate on that. Somebody with a pre-existing condition like a heart problem, if they go into severe withdrawal, and the more Narcan you give someone, the more severe their withdrawal is going to be, they can have an issue with a pre-existing condition from the withdrawal. But other than that, not, what it's going to do, it's going to go into your system. It's going to attach to those receptors. When the receptors are all filled, it won't go anywhere. It'll just float around in the system. So it's not dangerous to give somebody, too much Narcan, but it can be if that person has something going on already and the Narcan precipitates withdrawal if they're a regular user.
Gotcha. Well, thank you so much, Josh, for answering those questions and for that amazing presentation. Just so everyone knows, the CEs just got posted by Chloe in the chat. It says Josh Weil. And give it up one more time for Josh Weil from your